morning, everyone. I thank Dr. Subina for a very nice talk as well as inviting me here to be a part of this very prestigious team who's doing a very dedicated team who's doing a lot of work on ROP. So I take it further to the role of anti-VEGF and laser in the treatment of ROP. So as Dr. Subina has mentioned earlier, this is the stage 1 disease of retinopathy of prematurity. So when you have either an immature retina or you have a stage 1 demarcation line is visible, and what you do is a 1 to 2 weekly follow-up. Once you see stage 2, it needs definitely a weekly follow-up, and once stage 3 is there, you must treat within 24 to 48 hours. If you see something like this, that there is a flat neovascularization without any obvious ridge formation, you have to treat even further earlier, which is within 24 hours. And if you have aggressive ROP at your hand, as described by the previous speaker, we need urgent treatment. This is because the zone 1 ROP and zone 2 ROP may actually be two different, have two different underlying pathogenesis, where zone 1 is very aggressive and there is no formation of demarcation line because there is inhibition of normal vasculogenesis as well. So this is the indication of treatment which has been given to us by ETROP, and we generally follow this. Only a little bit where we can have some controversy regarding treatment. ETROP has mentioned that stage 3 zone 2 you could follow, but most of us feel that these patients may get lost to follow up, and so we definitely would still either follow them up closely or go ahead and treat. So once you have decided that you're going to treat these children, how do you do it? You have to have bilaterally pupillary dilatation. The procedure and drops have been covered well with Dr. Ajay. And make sure the child is fasting for about 30 to 45 minutes. Not too long, because you're going to do treatment under topical anesthesia, unlike the Western countries where the treatment is done under sedation or general anesthesia. If you plan to do that for some reason, then the fasting has to be more. Otherwise, half an hour, 45 minutes is enough, because during treatment, if the child cries too much, it will be again causing hypoglycemia. Informed consent, very important, which will probably be taken care later as well. And a quick general exam by either the anesthetist, and if you don't have really an anesthetist with you, just go through the previous discharge summary which the patient is carrying from the NICU, because that will tell you what other issues that the baby has had, and it will give you some indication as to what you can expect. So laser photocoagulation, indirect laser photocoagulation is required, and as Dr. Dogra has mentioned, that diode laser or a normal 532 ND YAG laser can be done. This is a regular laser which we have in the OPD, which we are using for all the other diseases of retina. We use it here as well. So this is a little small video which shows that how we are going to swaddle the baby. First, we do it in the operation theater under the care of an anesthetist. And so the ECG leads, everything is in place. It is applied so that we can monitor the baby. The pacifier is just during this procedure, and so that the child doesn't cry while we are preparing the child. And once this has been done, then you can see already the baby is dilated. Just monitoring on the Boyle's apparatus and the monitor are available. And here you just follow it up with paracaine drops. And then we apply a pediatric wire vectus is used along with the speculum, and the laser treatment is carried out. Once we start laser, then the pacifier, I prefer it that the baby is crying, and this we remove it. And this is so this is as sir mentioned, that we had taken cue from his treatment of doing laser through the incubator. And during COVID, when we had this similar issue where right in the very beginning we didn't know how it was spreading COVID and what we had to do, yet ROP laser had to be done. So we created something called the aerosol box, which is again almost like a thick plastic transparent container, and the baby was put in that, and we could easily achieve indirect laser photocoagulation through this. So this reduced the contamination of the full OR as well as exposure of the treating doctor to this. And this aerosol box in addition was also connected to a tube which used to take away the vapors, or the suction tube, and used to be put into the suction apparatus, so that the vapors or the exhalation of the child doesn't go to the atmosphere. So this is what we did initially during our initial stages of COVID, when we didn't have any vaccination or anything. So laser treatment technique, near confluent burns, light gray creamy burns are placed, and avoid treatment to the ridge in the first go. And if you are going to treat, then you prefer diode so that the hemorrhages and all are not there. But sometimes these hemorrhages can occur if you directly treat the ridge, so avoid it in the first sitting. This shows very nice how it can regress, and almost 94 to 95% of the cases do regress. Zone 1, it may come down to 60 to 70% regression rates, but still it can happen. And within 24 hours, you will see regression, especially of the plus disease. It can come by 2 to 3 weeks. You will see normal vessels glowing up to the aura. So when do you retreat? So if you see skip areas, or you see that the posterior ridge is forming behind the previous laser burns, or a localized TRD, and you have to go in again, take a call and treat. Side effects you could have is anterior segment ischemia, hyphema or cataract, and posterior segment accidental macular burn. So this should not happen, but since the baby is moving, it may happen initially in few stages, but best you make all precautions to avoid it. And since the peripheral loss can happen more, so that is where the anti-VEGF come into play. This is just sharing an example that inadequate treatment can sometimes result in a local kind of TRD in the area which has had skipped area with laser and not been treated. This was one rare example which the baby came from outside and had heavy laser, and in periphery or anterior to the heavy laser there was dialysis and had to undergo scleral buckling for reattachment. So as I mentioned, zone 1 or aggressive ROP, which does not respond very well to laser, anti-VEGF comes into play. And increased use of anti-VEGF was particularly seen in COVID because, again, reduce the amount of time spent doing the laser. So just quickly to show you that the BEAT ROP and Rainbow studies have shown that anti-VEGF, both bevacizumab, ranibizumab, and the newer one now aflibercept, is also useful, and it reduces both. Important thing to remember, it reduces normal vascularization as well, in addition to pathological vascularization. So the importance has to be given to the dose which is given. Normally we are giving half to 1/3 of the dose, but there are studies which have said that even lesser than that can be used, and it can be effective. But the problem is, if you use a very less dose, you will have to dilute the drug, which is usually not a good idea. So 1/3 to half the normal adult dose is enough. This is the injection kit which you should have before you start the baby with the injection, and a small video to show you how we do it in the clinic, which you can also follow. So again, the swaddling of the child has to be done, and again, if you can take care with the ECG leads so that your heart rate and everything is continuously monitored. To reduce the movement, we just gently take care that the baby is wrapped up nicely, and cleaning is done with povidone iodine, and then you can just drape the child with the single drape, and the eye only is exposed. Again, use the speculum to retract the lids after using paraffin drops. This is a case of tunica vasculosa which is persistent, and you can see that the eye is moving. That is because the treatment is only under topical anesthesia and the baby is crying. So you really have to be very quick. This is almost a real-time video and is not an edited version. And you can see that, once you measured 1.5 millimeter from the limbus, you just go in with the 30 or 32 gauge needle straight in and inject, and you can see this bleb coming. Gentle whitening is visible because of a transient increase in IOP, but you need not do paracentesis. This is a very small volume of the drug which will be disseminated, and IOP will be normal. So this is, as I said, safer ROP has now laid down these guidelines. It should be a shorter needle, antiseptic, follow-up of 2 to 7 days, extra attention to detail, and recheck. Follow-up, and follow-up is extremely important when you are doing anti-VEGF treatment, and especially if you're not combining with laser. You can do it in the NICU setting as well as in the operation theater, but in the NICU you have to be even more careful regarding the sterile conditions. Advantage is you always have a pediatrician or a trained help at bay, so that you can call whenever is required. Bilateral injection, if possible, avoid, but then more and more people are doing it to avoid any delay in treatment. Anti-VEGF can be particularly useful in aggressive forms of ROP, and if especially they present with exudative detachment, This was one of our cases where it was so extensive that there was exudative detachment, laser was not a possibility, and anti-VEGF worked very well. Disadvantage, major recurrences can be seen after anti-VEGF, and then crunch phenomena can be seen. Inadequate and peripheral vascularization is incomplete, so this will need attention. Sometimes total shutdown of blood vessels are possible. So a combination of treatments of using anti-VEGF as well as laser is again something which we all doing it more and more often, and this works very well even as a rescue therapy. So to summarize, we must treat ROP as per the most current recommendations, and you must keep all up to date to these recommendations. Oral and written consent, you have to talk to the patient and tell and the parents as to what to expect. Anti-VEGF, whenever is chosen, you have to emphasize the need for follow-up, and combination therapy definitely should be thought about in our scenario where the patients cannot keep up a long-term follow-up. Thank you.
Thank you, Dr. Parveen, for such a nice talk and such elaborate discussion. I'm so happy to look at this